This is a case of surgical resorption repair where we're actually looking at tooth number 27 here. This patient had had a recent surgery on tooth number 25 that was healing. They were referred because there was actually this odd-looking filling in the root of tooth number 27. And when we took a look clinically, there was localized swelling buccal of tooth number 27. So someone had actually already done a reasonable job of trying to repair this internally, but it was breaking down and there needed to be some sort of surgical intervention to take care of this recurrent area of infection that had now become symptomatic. So this was flapped. Okay, here's CT. And again, it shows someone did a nice job of packing some sort of material. It was hard to tell what it was at this point. Inside this tooth, but then this area had become a dead space that had become reinfected. So this is what it looked like preoperatively. This is what it looked like when we got the flap back. And there was actually some of the material out in the soft tissue, and then there was the granulation tissue in the area buccal to where the restoration was placed in the canal space. So we were able to clean that out and resect down, get a little bit of the bone away from where we were going to place the restoration. Inherent in most surgical repairs of resorption is going to be some sort of osseous recontouring and some sort of crown lengthening. So then we placed the Geristore, and we were able to finish that pretty well. It's really a critical factor in determining whether or not we want to attempt these, to determine how far interproximally the resorptive lesion goes. Because as it goes interproximally, two things happen. It will become more detrimental to the cervical strength of the tooth and much more difficult to treat. And doing crown lengthening interproximal will, by definition, involve the adjacent teeth. So when they start to go interproximally, usually I'm going to pull the ripcord and say, let's get this out and place an implant. But in this case, we were able to resect this buccally, place restoration. That's what it looked like when we were done. This is what it looked like at recall. And I like to show this case because that is incredibly healthy periodontium considering how far down below it we placed the restoration. What was really interesting about this case is it wouldn't probe. We know that that is Geristore down there. I just showed you the picture. This is probing in this area, and you can see the tissue is blanching, and I have that parallel to the root. This doesn't probe. So there's a lot of mysticism out there as far as what we get as far as some sort of attachment with Geristore, but I think it's fair to say the gingiva seems to like it a lot. And one time I was lecturing in San Diego, and there was a recent perio grad in the audience, and he said, one time I was pulling a tooth where the resorption had recurred, and that does happen. And he said when the tooth came out, there was something still in the socket, and he put his cotton pliers on it, and it was the Geristore. And as he tried to pull it out of the socket, it was attached to some sort of fibrous tissue on the buccal of the flap of the socket. And I said, did you get a picture of it? And he said, no, I didn't. But something was holding on to that Geristore, and I think that's what we have here too. So I thought that was an interesting result.